coming. Because the time restraint, I won't list every single person contributed. A huge amount of people contribute this program, and just list some example of the director of other department. Starting with a case, 39-year-old presented to ED with chest pain. Here's the CT has confirmed bilateral PE. She was given standard treatment in enoxaparin 1 mg per kilo twice a day. Little bit tachycardic, completely unsupported blood pressure. Hardly any oxygen requirement. She was admitted to respiratory ward. Just before midnight, had a med call. She mobilized to the bathroom. She developed PEA cardiac arrest, LAS, thrombolysis. After 60 minutes CPR, no ROSC. How can we recognize PE patient with high risk of cardiovascular collapse and death? Can we intervene before the arrest? Over the year, we have improved our standard protocolized treatment for PE, but this talk is going to focus on sick, severe cases. You can see the 30-day mortality in patients with cardiac arrest, high-risk PE, intermediate risk PE. Now we have increasing data about specific type, intermediate, high-risk PE, around about 10%, that's a lot. So how can we identify those PE patients just at the edge of the cliff? A little bit more PE, a little bit more thrombosis, go push the patient off the cliff, goes into this death spiral of PE. Increase RV afterload, reduce RV output, push onto the left side, reduce LV output, patient develops severe obstructive shock, then cardiac arrest. How do we identify them? This is a real cases. We have case 2, 59-year-old male, came to Canberra Hospital with just some general unwell, was bedbound for some days. He was referred to ICU next day because he had PE confirmed on CTPA. This is a nasty saddle embolism. We have a similar age, another male boarding by ambulance with chest pain, short of breath. Again, he is also confirmed to have a bilateral PE. Looks quite nasty as well. Look at the case 2's vital sign, a little bit tachycardic, unsupported blood pressure. You could argue whether he actually needs the oxygen, but he's on 40% of a high flow, 99 sats. He came to ICU, we did an echo, normal size RV, maybe mildly reduced function, he's got normal troponin. What about case 3? Little bit tachycardic. Well, MAP is 70, got perfusion pressure. However, his systolic about 90 plus. And the most important, I don't know how we can move my video. That's very important information for you. We did an echo. It's got evidence of RV strain. And the troponin is 400. Again, you have to believe me. So, who's in the... Oh, just drag it off. Okay, yeah, that's better. Actually, 800 troponin. So who's in the risk to collapse and death? Are we going to do something to stop them going cardiac arrest? So this patient underwent anticoagulation only, and this patient had advanced therapy. We'll talk about more later. So how do we recognize them? Is PERT the solution for this question? So this one we're going to go through. This one is talk about PERT, what is the history and about the evidence, talk about the guidelines, how do we re-stratify them, and some advanced therapies that are available now. We'll talk about what the benefit and the challenges and this proposed PERT pathway. History, PERT. The very beginning, the first PERT started from Massachusetts General Hospital in 2013. In 2016, they publicized the rationale, why, and how they organized the PERT. I'm not expecting to convince you just by all their reasons, but I think it's important to go through that. Firstly, we have high increasing incidence of PE, and some of them got very high fatality. There's a very limited evidence about particular those severe cases, and in fact, we need to save those severe cases. What about the rationale number 1? You have hearting, you have stroking, such as high fatality disease. Why don't we have a PE team? We need rapid, acute, accurate risk stratification. We have more and more treatment coming in, and we have some treatment going out. I think Glenn's going to agree with me. His surgical embolectomy is going out. And this is indeed multidisciplinary, tailored care for patient selection. Why don't we have a PE team? The second rationale is we have a very well-established rapid response team. Why can't we use the same pattern to save those patients? Not only that, the effluent limb is very difficult. Who is the one going to die? Who is the one that may not? And the second thing is we can rapidly mobilize a multiple team from one single point. So I'm sure I haven't convinced you yet. But this is the initial rationale, but I want to emphasize 2 things. Firstly, in their group, they included all PE patients. Okay, all PE patients. Secondly, they use a video conference. Why do I mention that? Because I'm going to tell you what actually they found. In 2016, they publicized their findings. They established the PERT in 314 patients in 30 months, average 10 a month. Sounds a bit similar to us. All-cause 30-day mortality PERT patient, 12%. I'm surprised with that number, 12%, all PE. How about us? I don't have the whole all PE data, but I only have ICU admission patient with PEs. What does that tell you? Those patients are high risk or intermediate high risk, whatever reason. But of course, I'm not including those patients sent to the ward, then arrested like the first case. So I have a limitation in my data. I want you to see before March this year, going backwards, 48 months, we have 63 PE in ICU, average 1 to 2 a month, sick PEs. The mortality you can see from here, hospital mortality nearly 16%. But I want to focus on this. Since April this year, in the last 4 months, we had 22 sick PEs, average 5 to 6 a month, and again, remain on a very high mortality rate. But compared to that, we're doing better, but still, sick PEs, we still have a very high mortality rate. So the best meta-analysis for PERT is that publicized in 2022. You can see, despite the fact that the PERT patient is sicker than the control group, 66% of are high risk or intermediate high risk. Despite this, we have less mortality rate. As a result, this part, PERT is written into guidelines with level 2A evidence. What does it tell you? We should have a PERT team. So talk about guidelines now. I'm going to mostly use 2019 ESC. Hands up if you think that needs to be updated. Yep, there's more coming updated, but this is what I have so far, okay? Not only that, this is the first guideline have a very clearly delineated the high risk P and what to do. And you have found that this is the major guidelines in CHS, in the American Society of Hematology, as well as a summarized guideline in New England Journal of Medicine. But I'm just going to tell you, I'm going to focus use ESC 2019 guideline because the majority of the content is very similar. So now comes to risk stratification. Straightforward. Who is the high risk? Whoever has hemodynamic instability. Straight away, you are high risk. There's three types. One, cardiac arrest. Secondly, obstructive shock. I think look at the golden number, okay? Golden number 90 and evidence of shock. And persistent hypotension. You don't have evidence of shock, but you have persistent systolic less than 90. Why do I say persistent? Because you can immediately correct your arrhythmia. You can give fluids or blood, resuscitate the hypovolemia. With all these treatment, you're still hypotensive for more than 15 minutes. That is high risk PE. Okay. So you don't meet the criteria of a high risk P. You come to intermediate. You assess RV dysfunction and you measure cardiac troponin level. If you got both RV dysfunction and high troponin, you go into intermediate high risk. But if you have only one of them or you have none, you are intermediate low. I'm going to talk to you later how do you differentiate intermediate low and low risk. So if you look at the RV dysfunction, okay, sure, you can see CT, you can use echo, you can use all the rest of it, but I want you to focus on this odds ratio. The odds ratio with CT, 2.5. The echo odds ratio, hugely higher. Therefore, echo is the actual standard criteria to diagnose RV dysfunction. In the guideline, there's very clear that I'm not going to list the signs of assessed RV dysfunction. You can go through that. So you have the patient intermediate high with both RV dysfunction and troponin. And you only have one of them, you count it into intermediate low. And the question, people started thinking, what about PESI? PESI score, Pulmonary Embolism Severity Index. Now, I want to say this endpoint for this score is 30-day mortality, okay? You can go into the original version. Oh my God, so many numbers, but a very, very clear what score you're going to have what mortality, right? But it's not practical in clinic. So we're going to use simplified version. If you look at the simplified version, simplify into 0 or 1, or more than 1. And the risk of death in 30 days is 1% and 10%. What does that tell you? PESI goal is not for you to use rule in severe PE. It's actually like a rule out your severe PE. So this patient, if you do not have any PESI score, for example, golden number again, pulse rate more than 110, systolic less than 100, but you're not high risk, you're more than 90, isn't it? But you're less than 100 and you need oxygen. This is the 3 things I'm going to repeat again. If you have nothing of this point, you go straight to low risk. You do not even investigate with echo or troponin. So this is how you go through the risk stratification. We're going to do a bit more exercise, don't worry. So, medical student, can you tell me what is the risk score for case 2 and case 3? Case 2? There's lots of students there. Is it high risk? Is a high risk patient? He's shaking his head. No. Is that mean intermediate risk? What's the definition of intermediate risk? So you're not high risk, you're not categorized, you're not obstructive shock, you're not persistent hypertension, right? You're not high risk. Are you low risk? No, because you got score, PESI more than 1 PESI scores. So you're intermediate. Agree with that? But in the first case, you have only mild RV dysfunction, normal troponin, you are intermediate low risk. The second patient, you have RV strength, you have high troponin, you are intermediate high risk. Does that make sense? Okay, because otherwise I'm going to get more into that. So now I'll talk about advanced treatment. I think I'm not going to teach people how to suck eggs. And we're very good at thrombolysis for high risk PE. Sam would agree with me. So you have patient come to you say high risk PE thrombolysis, standard regimen, but I want to emphasize to you, cardiac arrest not using standard regimen. You use 50 milligram push plus minus second, but you need to carry on with CPR more than 60 minutes. If you look at all the guidelines, although the wording is a bit different, right? Okay, so this one says, oh, if you have hypotension, this one says hemoglobin compromise. It's the same. You have high risk PE thrombolysis. Simple. What about intermediate PE? I'm not high risk PE, but I'm intermediate. You read through the PETO study already. When they thrombolyze patients with intermediate risk, they have less likely to die, but they have a huge amount of bleeding risk. Some of them are major bleeding. That's why, at the moment, all the guidelines argue against routine use thrombolysis for all patients, but didn't say you can't do it with selected patient. But they highly recommend we need to closely monitor them for rescue thrombolysis if they're falling back, continue to deteriorate. So the question will be, we have a higher risk group within the intermediate risk. Can we save those intermediate high risk PE but without causing more bleeding? So there's a study we're going to do two directions. One is, can we have half those? Can we have a safer method? And the second one is, can we have a different intervention to stop them going to deteriorate? Talk about catheter-directed therapy. It's not new. If you read under this guideline, it's already mentioned in the past, catheter-directed thrombolysis, catheter-directed thrombectomy, etc., etc. However, clearly they were saying there's a like high-level evidence. Therefore, if you can't go to the next page.
It's actually not allowing us to go to the next page.
So you carry on. I will. If you click to my slides. So in the guideline, all guidelines make it very clear. Catheter-directed therapy is indicated if you have high risk P, but you cannot thrombolyze. Yep, thank you. So contraindicated for thrombolysis or failed thrombolysis is recommended going to catheter-directed therapy. So in 2018, Society of Interventional Radiology has publicized their statements. I fully support high-risk P, contraindicated or failed thrombolysis. However, they say there's insufficient data to support the intermediate risk. But we're not going to wait until the randomized control study. They will take a time. So the question for us, is it safe for the intermediate risk PE patient? Who actually will benefit from it? So is it safe? It's actually since 2014, you can see there's a multiple studies just investigate the catheter-directed therapy. The first one, Ultima and the other two, was actually catheter-directed thrombolysis. And the FLAIR and also the Indigo system is more suction or some type of mechanical thrombectomy. So what is good about all this study? Hardly any bleeding. What's bad about this study? All single arm, of course, is low level study. And nextly, what is the endpoint? None of them is patient-centered endpoint. It's all the measurement of the pressures, of the hemodynamic, etc. So what can we do about this? But at least we know they're safe, they're doable. And one of the things is about, if you see the inclusion criteria is all variable as well. So they're low-level evidence. But right now, around the global world, there's a lot of study goes into these details, who will benefit from this therapy. So this is my favorite, one of them. Why do I like it? Because they integrate with PERT. So this study integrate with PERT activation and catheter-directed therapy. So the inclusion criteria, number one, say massive PE, or you say high-risk PE, contraindicated or failed thrombolysis, goes into catheter-directed therapy. Intermediate rates, remember those golden number? 100, 110, oxygen. Those patients, they start anticoagulation, then they wait. In the next 24 hours, if the patient deteriorates, catheter-directed therapy. If the patient 24 hours later not deteriorate, but none of this number is back to normal, goes into catheter-directed. This is one way, one study only, okay? We'll get many ways. So what I want to show you is, in the intermediate high risk, the 51 patient, there's a 9. So round about 9 out of 51 has gone into catheter-directed. And in high risk, 5 out of 19 gone to catheter-directed. What I want to take to the message is, not every intermediate high risk patient needed catheter-directed therapy. And some of the high risk patients require catheter-directed therapy. Now, again, they're not patient-centered outcome, but they have demonstrated significant change in hemodynamic, in RV function, in RV size. So that's evidence reduced pulmonary artery offload. But I tried to sneak into some finding about patient-centered. So altogether, 14 patients had a catheter-directed, no bleeding, no PE-related death. They have one patient died from hypoxic brain, and that patient was in high-risk group. Unfortunately, they reported 2 deaths at 3 months, but they didn't tell me is it intermediate high or high-risk group. So that's not reported. I calculated. If I say I count that 2 patients, both intermediate high, they have intermediate high PE, high-risk PE, 3 months mortality, 3.9. Wow. I hope that's a reality. So we have a limited evidence. Everyone's doing it a different way. Well, how would do? Who do I refer to catheter-directed therapy? So right now, high-risk patient when you systemic thrombolysis is contraindicated or failed. Intermediate high-risk patient, and you consider that as a high risk of cardiovascular collapse or death. Or you can sit, able to wait, given the standard treatment for 12 to 24 hours, then you decide whether that patient has improved coming out of your intermediate high risk PE standard. So in the guidelines we are for the consultation, so we think this must be a joint decision from multiple teams, and it's based on your degree of cardiopulmonary compromise. Remember that golden number, less than 100, systolic less than 100, heart rate more than 110, needing oxygen. And then you look at the degree of RV strain as per echo and troponin. The common sense is severe is bad, worse than moderate. And the 3-digit troponin is worse than 2-digit troponin. So looking at those, combined with this result, I'm going to tell you about the BOVA score. The difference about BOVA score is the BOVA score is developed specifically for intermediate risk patients. And as you can see, again, they're using all this golden number. Again, isn't it? But the only difference at the end point outcome is 30-day PE-related complications, not just death. So BOVA score is giving you a rough idea at 3 months down the track, what is the risk of the patient have PE-related complication? And if you calculate the score, that's the number all there. So that will also help you to decide what's my BOVA score. The BOVA is more than 4, and that's also telling you the patient might benefit from catheter-directed therapy. Of course, you have to talk to intervention radiology. Is that doable? What if it's all peripheral? They can't do anything. So you can look at the burden and location as well with the multidisciplinary decision to go into these catheter-directed. There's a huge list of contraindication in the pathway if you can go back to it. So we have low evidence, but are we going to stop doing it? 43-year-old male, she had ankle fracture a month ago. She's on enoxaparin prophylactic dose, 20 milligrams. He went to Kumar Hospital with severe hypoxia. That scan showed bad saddle PE. And she was given another 90 milligrams of enoxaparin as per weight. And she had a little bit TIA-like symptoms as well. She was transferred here with troponin. You can see tachycardic, less than 100 systolic. She absolutely needing oxygen. She was actually on NIV 70% FO to bad RV strain. So this patient, there's a discussion, can we normalize her? There is a worry about 110 milligrams of enoxaparin just been given, as well as a TIA-like symptoms. In fact, later on, we did find the patient had PFO. So we can't normalize the patient. The patient is high risk. We went into catheter-directed therapy. Patient was intubated, ventilated. During the operation, the PA pressure from 60 systolic come down to 42 and rapid improve of resaturation. What do you think about the rapid improve saturation? Because you rapidly reduce RV pressure. And see the PFO, because you get the pressure is high, PFO will a lot more shunting. That's why you have dramatic improvement in her oxygenation. I'll just quickly show you. This is prior to thrombectomy. hardly any flow on the left side, just the example. Then with Dr. Lalou put a catheter in, started to suck the clots. There's a few clots left over there, blood goes to the bottom. We did a long time that case, about 2 hours, 2 or 3 hours, 3 of us, and plus all the intervention radiologists. This is not the final outcome. It's in the middle. It's in the middle when you are doing the suction and the repeated the angio on the left side. It's really about significant improvement. And this is not this patient, but this is one of the other patients who did the clots sucked out from the catheter therapy. Okay, the patient was went into the back to ICU. Remember the dramatic improvement in oxygenation within 6 hours. Extubated. She stayed in ICU for 2 days. We actually booked the bed on the second day, but bed blocked 1 more day. So 3 days later, she went to the ward, and guess what? She only stayed at the ward 1 day. She went home. Okay, what about VA ECMO? I'm just gonna, what about this advanced therapy? VA ECMO is when you got cardiac, completely severe cardiogenic shock. For PE, it's severe obstructive shock and impact on the left side, completely no cardiac output. So we put a cannula. One is from in the big vein. Then we get a return cannula going into arterial system. So using this pump function, pump the blood back to arterial system as a surrogate of your heart to provide perfusion to the rest of the body. So it's a temporary extracorporeal support, life support, while we're waiting for your heart to recover. So this is called a VA ECMO. So if you look at the guidelines, well, you say maybe. Why? We don't have RCT. But are we going to stop doing this even if we don't have RCT? So we'll have to admit, yes, there's a lack of RCT. In the meantime, a lot of patients, when they're sick, there's after thrombolysis. Once after thrombolysis, they easily bleed everywhere. It has a big impact on our procedure and the survival as well. So there's a limited RCT. There's also interesting meta-analysis in 2022. So the first one is actually they did all VA ECMO for PE and control. And I say, no difference to short-term survival. Seriously? Anyone on VA ECMO, they're much, much sicker. So I kind of ignoring that, but anyway. So the patient much sicker. Then they say there's no difference in short-term survival. Then they say age more than 60 associated with lower survival. And the other meta-analysis is actually just to do the patient PE with cardiac arrest. And I'm actually quite excited to see PE with cardiac arrest with VA support, 61% survival rate. And they also mentioned about there's no difference whether you pre or post thrombolysis. And again, mentioned about age more than 65 associated 3-fold risk and ECMO CPR 6-fold risk. What does that tell you? Don't wait until the patient arrests. If the patient needed VA ECMO support, we do it. And if the patient had 1 cardiac arrest and you quickly get back, those patients may benefit a lot, particularly the sickest group of pulmonary embolism. So we will do it, even we don't have evidence, but because there is a many other reasons. A 69-year-old woman, she presented ED after 4. Then she had a fracture. Then she had a theater, had ORIF, and put a nail. Next day, midday, she had back cold. Suddenly her systolic 70 above. She also become unconscious as well. She given fluid bolus, she given some metronidazole, she's improved. Become blood pressure kind of not supported. Then we managed actually get her to the CTPA prior to she come to ICU. And this is her CTPA. Not that exciting, is it? Someone's like, okay, all right. So I want to ask the medical students again. So here's the timeline. She had a med call with systolic 60 here. 1, 2, 3, 4, 5, 6 hours. She's been hypotensive until she arrived ICU, unsupported blood pressure, systolic above 100. Medical student, what's this patient's category, risk category? And I wasted my all my.
Yeah, I think you're gonna struggle to get an answer.
Anyone, right? Hands up. Is this a high risk? We need more hands up. This patient clearly high risk, isn't it? So, of course, ICU say this is a high risk patient. Let's thrombolize her. During thrombolysis, she had a cardiac arrest. PEA cardiac arrest, several cycles. She was intubated, ventilated. She persistently required a lot of inotrope support blood pressure. We put her on ECMO. She was transferred to, I think it's RPA. After some days, she would return. 3 weeks ago, I met her in the patient day, and that's her. Oh, I've stuck again. That's why I'm probably in the class.
It's not you, Tina. It's the system. Second, if we go over here, and then we go back over here.
I can't remember what's my next slide, so.
Closing it out.
Yeah, it's really not.
Okay, very good.
So
That's right.
here.
Yep.
It doesn't like that one, does it? Okay, I'll try it again.
So I very much, if you look at that slide, I've just explained the options of advanced therapies. All right, we have the options. We need to get the team all together, find what's the best tailored treatment for those particular patient. My next slide is the benefit.
Oh, is that the one?
First one, next one. Yes. Okay, let's summarize. What is the benefit? Rapid assessment risk stratification. Identify those patients who have high risk of cardiovascular collapse or death. Multidisciplinary senior input. We have a single point of activation of all kinds of advanced therapies, and we have tailored treatment to each patient. Lots of challenges. Resource restraint, some teams do not provide 24/7 on-site services. Additional category 1, procedure for anesthetics. I'm sure they agree, but actually, sometimes it may not have to be a category 1. We can discuss that. Then resource restraint, another urgent IR intervention, often after hours. We're really stretched our resources already. Heavy relying on echo for risk stratification require training and certifications. There's so many highly specialized therapy, ECMO, catheter director, we require ongoing training and quality control. Low experience, intense resource demand, case selection at the moment. You might find we're more stringent now than some other places. Low level evidence, risk of inappropriate use. Do not have knee-jerk response when I have a patient. Look at the patient, not the CT scans only. And ever-changing evidence, changing guidelines, and changing practice. So if you read the pathway we propose we propose PERT pathway. Activation criteria were made very clear. You have to be high risk or intermediate high risk. High risk, almost immediate refer. Intermediate high risk, you need to go have a look at the echo, get the troponin before. That's why it's his delayed refer. But once we confirm intermediate high risk, P refer to the PERT team. And the PERT team, of course, I want as many members as possible, but it's not possible. So ED patient, we have ED respiratory. I have to put the bracket when they're on site because it's not always on site. ICU 24/7, sorry. ICU in the daytime, referral team. In the nighttime will be most senior doctor and cardiologist if requested ICU. I can't ask enough for every single PERT because there's a resource strain. 24/7 services, call switchboard activation, all team member goes in to review the patient, discuss, involve your senior physician on each team, discuss the best treatment, and activate rest of the team as appropriate. So to emphasize the very beginning, we'll talk about risk stratification. So you have a PE, Or some people you actually didn't get a chance to be able to do a CTPA, highly suspect PE. First question, is this high risk? Do you have any of the one out of the three or more than that hemodynamic instability? Yes, PERT. Then decide thrombolysis or other treatment. Then you say, I don't meet high risk, but I meet one of these bad gold numbers. So if you meet any of these gold numbers, remember, PESI says your risk of a 3 months mortality risk from 1% to 10.9%. So you have one of them, you investigate. Investigate RV dysfunction to opponent. If you have both, you are intermediate high. You refer to PERT. If you are low risk, you have zero, none of this factor. You don't even need to investigate. You are low risk, or you only have one of these, you are intermediate low risk. So once PERT people get together, all the specialists or discussion, so we will decide, okay, every single person needs anticoagulation. No question asked unless contraindicated. Then systemic thrombolysis. If it's contraindicated for failed catheter-directed therapy, now I didn't talk much about surgical embolism. It's a very unusual some indication for surgical embolism. Now also always think about ECMO. We use groans. We need the groans, similar to ECMO. And ECMO can be bridge to recovery, bridge to intervention as well. It's possible that we actually make patient meet ECMO criteria. We put on ECMO before we send to IR to the catheter-directed therapy. So this will be combined all the senior staff in the PERT team to make that rapid decision. Take-home messages. I don't say incidence of PE, I'm just even talk about us. PE and its severity is increasing. High risk, intermediate, high risk PE continues to carry very high mortality and morbidity as well. Rapid assessment, risk stratification, activation, advanced therapies in selected patients, mainly to survival benefit and less PE-related complications. PERT enables multidisciplinary senior input and ensures tailored treatment for high risk or intermediate high risk PE, particularly in some area, lack of strong evidence. That's why we need to sit together to make that decision. PERT also requires constant training, education in evaluation of advanced therapies. We have organization-specific challenges, but we have to overcome it, and collaboration is the key. Thank you.
Thanks very much, Nina. We've got about 5 minutes for questions.
Thanks, Tina. Thanks. That was really great. I just wondered, in the PERT team, is there a nurse be considered to be part of the team? I'm just thinking of the stroke team, just so that the trauma team, just to follow the patient from essentially from the start of their journey to when they go home.
That's a really a luxury. It is absolutely so. One of the things we thought about is coordinator, like a semi-stroke nurse coordinator. We thought about that. Again, that's another resource requirement. And the good thing is, if you get whole program going, if we have that kind of luxury, it's absolutely beneficial. But we can discuss how we make that happen, because we're going to build REDCap PERT database, as well as will be part of the PERT consortiums, and so those will be next step. I'm not sure whether nursing needs to go to the PERT team, the PERT itself, because most of the decision actually made the complex medical decisions. But being a nurse, being coordinator, and follow up through, fantastic.
Happy to come.
Any other questions? Let's check online. Can't see any questions online.
I'll say to give you short. The pathway seems very clear to me. Why do you need the multidisciplinary unit? I mean, surely one person can be at the bedside and say, this is a high-risk patient, systemic thrombolysis if it doesn't work, or in the interventional radiologist. I mean, it seems very clear.
Yeah, that's why we do this talk as well, the pathway. Before we talk about, I'm sure there's a lot of cloud as well. There's a lot of knee-jerk response. I have a patient with PE, horrible CT, intervention radiologist. So that's why, like I said, if you follow the pathway, is actually assess the patient first. So I just hope that actually helped the rest of people understand the pathway. Yeah.
So you're saying to me that essentially having those extra brains is going to stop somebody just jumping on and kind of misinterpreting the pathways.
Yeah, I'm trying to do the education. So I agree. I try to make the slides, talk to many people, make sure that actually, if you follow that slides, it's actually clear. But when you got new technology come on, it always happen. So that always happens. We should, without even seeing this, go straight to but you're right, follow the pathway very clear. You're meeting the criteria too.
I think partly because it's a evidence-free zone, we have very
Yeah.
low level of evidence for those pathways. They are actually emerging technologies. And so if you minimize how we use the CDTs, they also come with their own risk.
All right, I think we've run out of time. Oh, sorry, one more question.
Oh, yeah, you talked about the bleeding complications. Obviously, I've got a great interest in bleeding complications. So how much of that is gastrointestinal bleeding existing for intrasterile?
I'll just repeat the question. So Dr. Powell was asking how much of the bleeding is gastrointestinal bleeding?
From intracerebral, I mean, intracerebral is disaster.
Yeah. So
Gastrointestinal.
yeah, so the best one is actually the PERT study outcome. So for PERT, there's a different risk. Systemic thrombolysis itself for high risk, systemic thrombolysis for the intermediate rate, you will see huge amount of major bleeding and some major intracranial. That's why it was spoken against for intermediate risk patient to have everybody get thrombolysis. But for catheter-directed therapy, the major, as you can see, 1 or 0 major bleeding. Why? Because they're just going through the ground. The major bleeding, mostly the one is just the major, is the vascular hematoma, that thing. So when you've got the risk of bleeding, thrombolysis itself, we know carries significant bleeding. Some of them critical intracranial bleeding. That's why we're going away from thrombolysis, particularly for the patient intermediate risk, not routinely doing that. Even they're higher risk, we're thinking about something less bleeding risk. For example, half dose thrombolysis, for example, catheter-directed therapy.
All right, in the interest of time, we'll have to wrap it up. Thank you, everyone.